Hello everyone, welcome to Gynecology and Obstetrics Emergency EMQs. This is a very important topic for your exam, and often it goes wrong also because these need to be managed as per the RCOG protocols, and you are basically most of the times actually you manage according to your own practices, and that's where we go wrong. So it's very important that you just see this, that you know what are the protocols, how to manage this. This is very important. So that's why this is very important topic. So we will be covering almost 10-12 EMQs in this, and then um, I'll be reading the questions and you all will be answering the questions, and I'll be checking all the answers in the chat, and then we'll discuss why this is the answer. And simultaneously, we'll also come to know how we have to solve the EMQs, what is the correct way, because always we need to fix up the answers before we go to exams. For EMQ, this is the trick. Formulate your rules and fix your answers. If you do not formulate the rules, then we are here to formulate the rules for you, and you can be with us. So welcome everyone. I can see, yes, many of you have joined. So can you just say hi or something so that I know the names as well? It will be very nice to have you around. So yes, something, yes, I would like to see who all is there. So can you just say hi or something? Who all has joined? Yes. Okay, great. So let's start. Let's start with the first question. And then as we go further, you all can keep answering. And the one who answers first their name will be announced here. For every question, I'll be taking the name of the person who is going to do at the earliest, fastest finger first. So yes, Dr. Shalin, Dr. Sunita, and Dr. Yamini. Great. Okay, so let's start. So here we go. So choose the most likely complication after myomectomy or embolization and each of the following cases. Each option can be chosen once, more than once, or not at all. So here is the question. Mrs. F is a 45-year-old para 2. She was diagnosed with submucosal fibroid for few months. Her periods are getting heavier with many occasions of flooding. Finally, she agreed to go for the hysteroscopic myomectomy. All her preoperative investigations were satisfactory. After 60 minutes of her operation, her oxygen saturation started to drop from 96 to 70%. Anesthetist noticed also there is increasing swelling of her face and neck. He decided to intubate her, but there was marked laryngeal swelling, which forced him to do tracheostomy. So what is the correct answer for here? Okay, the answer is already there by mistake. But anyhow, yes, I would like to hear the correct answer and why that is the correct answer. Why you think this is the correct answer? That should also be there. Yes, I could see the answers coming up now. Yes, there are two answers as of now. One is pulmonary edema, another is anaphylactic shock. Yes. Yes, I can see two answers. So anybody can write also in chat box. Why do you think M is the correct answer and why do you think N is the correct answer? And how can we differentiate between the two and what's actually happening here? So, yes. So basically, this is a hysteroscopic myomectomy, right? So these patients can go into the fluid overload. And as the fluid overload is there, then there is basically the more the fluid is there and the heart failure. Heart failure leads to accumulation of the fluid in the spaces. That leads to pulmonary edema. So pulmonary edema is the correct answer. It's not anaphylactic shock because there is no such allergic kind of thing here. Nothing which is given and which has led to this. Predominantly, it is hysteroscopy which has led to the fluid overload. And this fluid overload has led to pulmonary edema. So that is the correct answer. Yes, and this is the case of fluid overload associated with hysteroscopic myomectomy. The clues in the question are low oxygen saturation, swollen face, and the difficult intubation due to laryngeal edema. Pulmonary embolism is a possibility, but edema is more likely with the hysteroscopy. The hysteroscopy, the procedure which is mentioned here, is itself a clue to this. And it's a very important tested point, that is fluid overload in hysteroscopy. How much is the limit? When do we stop? These all are exam related questions. For hysteroscopy, this is one very important point. And who is the fastest finger first? That is Priyam 5771. That is the fastest finger first. Okay, great. Yes, good evening. Very good evening, everyone. Okay, so let's move on to next question. So Mrs. R is a 22-year-old para zero who is originally from Nigeria. She was admitted to the accident and emergency department because of sudden collapse. On examination, she was extremely pale with a pulse rate of 123, blood pressure of 87 by 54. On abdominal examination, uterus was not palpable, abdomen was soft. Internal examination revealed fetal head-like structure low in vagina. The pregnancy test is negative. Now, what is the possibility here? What is the possibility here? So what is happening here around? Yes. What is the reason and what is happening in this question? Pregnancy test is negative. So definitely we are not dealing with the ectopic scenario because that's the one which we most often see such a picture where you have a collapse and the hemorrhage signs are there. But this is not that. So what is this? This is basically a fibroid which has just come out in the what is there, but it is says that fetal head like structure low in vagina. Now what we can do in this case basically, so yes, it is fibroid which is in the vagina. It's basically the prolapsed fibroid. Now what we can do for this, what is the correct answer to this question? Yes, yes. F is one option. That is examination under anesthesia. What else? What else? What else? What else? Again F, another F. Yes. Then comes M. Okay. Okay. So we have got F and M, two options. Any more options? I'm looking for more answers. Myomectomy. Myomectomy is only not an option. There are different options for myomectomy, so you have to choose which one is the best. Again, F. So I have got F, M, and another is myomectomy, but myomectomy is not an option. We have to choose the options from here. So again, F, M. Okay. So because it is vaginally prolapsed, right? So we can just remove it vaginally. So that procedure will be vaginal myomectomy. Okay, so the correct answer to this question is vaginal myomectomy. It will not be only examination under anesthesia because you will have to remove the fibroid. Okay, so if it is a pedunculated fibroid, which is just coming in the vagina, so you can do the vaginal myomectomy. So vaginal myomectomy is the correct answer. Okay, now coming to the next scenario, and who is the fastest finger first for this? Dr. Sunita Yadav. So 3 cheers. Very good. And let's go on to next question. So Mrs. F is a 48-year-old para 2 who is admitted to the surgical ward because of acute intestinal obstruction of unknown cause. Apart from a history of fibroid uterus, there are no other surgical or medical problems. The surgeon has asked for gynecology input, even though you thought it was very inappropriate referral. On abdominal examination, the uterus was 18 weeks in size, the abdomen was distended and very tense. MRI scan has confirmed the presence of 16 centimeter fibroid deviated to the left with the loops of distended bowel around it. What is the most appropriate management for this patient? 18-week size uterus, abdomen is distended, very tense. MRI scan has confirmed the presence of 16 centimeter fibroids deviated to the left with the loops of distended bowel around it. Now what? Now what? What would be the correct answer here? So that will be now in this case, of course, you have to do the myomectomy. But what kind of a myomectomy will be there in this particular question? So because it's a 16 centimeter fibroid, right? A big fibroid, which is causing the distension, deviated to the left with the loops of distended bowel around it. Pressure symptoms are also there. So definitely needs removal, and we will need to do the open myomectomy. So laparotomy and open myomectomy would be the correct answer. So answer is the C. C option is correct answer. And once again, the winner is Priyam 5771. That's great. Okay. So claps because you have got the second answer, fastest finger first. So here is the applause for you. The third question is Mrs. LJ is a 28-year-old para 3. She had a Mirena coil inserted with antibiotic prophylaxis in a family planning clinic 8 days ago. Since that day, she has been having very severe pelvic pain. She wants her coil to be removed, but her family doctor said to her that she should preserve for a few more days because pain can sometimes happen after coil insertion. What we can do now? What to do now? What is the most appropriate management at this point of time? Okay, so C option, is it bowel injury? What else could be there? She is having a severe pelvic pain after coil insertion. So what could be the possible things? Again, C option. So, okay, C goes with the bowel injury. There, what else? What else? What else? Looking for more answers, waiting for more. B, okay, reassure, normal, okay. Then it is I, that is urinary retention. Then it is K, coil perforation. Okay, okay. There is K, I, B, C, ruptured ectopic. Okay. So basically, let's talk about the correct answer. So what is happening around? What can happen after this? So either there is a coil perforation. See, bowel injury will not directly occur. First, the coil has to perforate the uterine wall. It will go inside. Then only it can lead to further injury. This is not suction evacuation. Anyway, anything in the uterus need to first perforate the wall and then only it can go on to the bowel. Secondly, of course, it is not reassured because it's already mentioned that she is such a severe pain that not relieved by the medications, and also they have also ruled out the infection because they have told you that the antibiotic prophylaxis is already given. So by telling that the antibiotic prophylaxis is given, they have ruled out chances of infection. So another thing is because it's a severe pain, she want to get her removed, and also her doctor has already told that this can happen after coil insertion. So that means they have ruled out the reassure part as well. Now, what can happen with the coil? The most important thing which can happen is the coil perforation, and that can lead to pain, severe pain. That can be a severe event. So the correct answer is coil perforation. And this time again, third time, the fastest finger first is Priyam 5771. So that's a very, very good thing too. Very, very good preparation, Dr. Priyam. Nice. So this is answer K. K is a correct answer. So yes, that's good. Many others have also answered K. So this was a tricky question, but well attempted by Dr. Yashasvi and the three amigos and Dr. Arohi and Dr. Priyanka Singh. So these all have attempted it correctly, and it was a tricky question, but nicely taken up. So what things can be there with the coil? One answer can be reassure, but reassure is ruled out. Bowel injury can only occur, or the other organ injury can only occur once after the uterine perforation. Toxic shock syndrome is another, but there is no fever mentioned here. So therefore, K is the correct answer. Now coming to the next one. Miss DL is a 44-year-old para 1. She had thermal balloon ablation 4 days ago. Came into the accident and emergency with acute agonizing lower abdominal pain for 5 hours. On examination, there is a rigid abdomen with generalized tenderness. Pulse is 120 and BP is 156 by 105 millimeters of mercury. Now what? Now this is 5 hours after the surgery, acute agonizing low abdominal pain, and now they mention the two keywords here, which is rigid abdomen with generalized tenderness. Now, these are the very specific keywords for what kind of a situation. Let's see who is going to answer this correctly. Yes, D, B, okay, D is ruptured ectopic, B is reassured. Okay, I think these are the previous answers. I'm looking for the new answers for this particular question. Yes, what could be happening here? What is the possibility? What is the possibility? What is the possibility? What is happening here? No answer yet. I'm waiting for the answers. Yes, yes, yes. Nobody would like to try this? Or I can't see the answers coming up. Okay. Is it so tough? Okay, so now the rigid abdomen and generalized tenderness, they are keywords for your bowel injury, right? So in this case, but particularly with these keywords, this goes in favor of the bowel injury. So here the correct answer is bowel injury, right? Particularly because of these two keywords. Rigid abdomen with generalized tenderness, which was not there in the previous question, where we were choosing the bowel injury when some of the students were choosing the bowel injury, right? So, but there, this kind of a thing was not mentioned. So here, rigid abdomen with generalized tenderness makes it specifically the bowel injury. Okay, coming to a long question, a typical RCOG scenario, which is particularly a long question. So Mrs. Q is a 36-year-old para 1, healthy and fit. She had an uneventful low-risk pregnancy with normal investigations. Delivered her only child vaginally 12 hours ago. Male baby weight 3.891 kg. Her first stage lasted 10 hours and the second stage lasted 80 minutes. It was a normal vaginal delivery complicated by second degree tear, which was sutured by the doctor. Estimated blood loss was 450 ml. You were called to see because of worsening abdominal and vaginal pain. Midwife said she gave the patient 2 injections of pethidine, that is 100 milligram each IM, over last 12 hours. Blood pressure is 110 by 76, pulse is 85, temperature is 37.1. On examination, lochia is minimal. Uterus well contracted and internal examination was difficult and painful. What is happening around here? Now, what is the scenario and what is happening here in this patient? Yes. So, who is going to answer first? Fastest finger first. Who is going to get it right? So Mrs. Q is a 36-year-old para 1 healthy fit and she delivered 12 hours ago. And then it was a second degree tear. Estimated blood loss was 450 ml. You were called to see because of worsening abdominal and the vaginal pain. Midwife said she gave the patient 2 injections of pethidine over last 12 hours. Blood pressure is 110/70 and pulse is 85. Then it is 37.1. Temperature, so internal examination was painful and difficult. What is happening around here? Anybody would like to answer this? Yes, waiting for the answers. Yes. So it is H, 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 E. These are the main answers here. So H, H, okay. So H is the correct answer. H is the correct answer. Perfect. And the first one to answer H is Dr. Sunita Yadav, and second one to answer is Dr. Arohi. So very good. You have done it right. This is basically the vaginal hematoma. That's a correct answer here. So this is vaginal hematoma. That's perfect. How do we say this is vaginal hematoma? Because you see the internal examination was difficult and painful. And what is the key word here? That she has given already 2 doses of pethidine. That means whenever it is an agonizing pain, always think about either the hemorrhage or the sepsis. And definitely immediately after the after the surgery, we are not looking at sepsis. This is predominantly, and you can see other things are also stable, not regarding the sepsis. So it is a concealed hemorrhage. It's a hemorrhage which is basically secluded, not a constantly ongoing hemorrhage. So that is the vaginal hematoma here. So very good. Now I want more people to be the fastest finger first. So please be active and I want others to be fastest finger first for the right answer. So Mrs. KM is a 39-year-old para 2 had elective cesarean section 12 days ago for previous cesarean section and fibroid uterus. During second operation, she had massive postpartum bleeding, which needed B-Lynch suture, uterine artery embolization, and 12 units of blood. She is febrile since the operation and having profuse purulent discharge from the wound. She is on parenteral antibiotics and her most recent blood culture was positive for E. coli. Very good. So, one of the answers, G. Yes, another G, another G, another G. Yes, 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 yes. Yes, it is G, G, yes. What else? What else? Yes, good. Everybody coming up with G, another answer which came up as D. So basically, I think this is purulent discharge from the wound, febrile patient. So I mean, likely to be sepsis. So uterine sepsis is the correct answer. And this time we have a new person with the fastest finger first, and that is Himi6176. That's the username. So, very good. A round of applause for you. So, uterine sepsis is the correct answer. Now we move on to next question. Mrs. Alex is a 28-year-old para 2. The last child was delivered 10 days ago by emergency cesarean section for fetal distress and preeclampsia. She was discharged home on day 4 in good condition on oral antihypertensives, labetalol 200 milligram thrice a day. Her blood pressure was 140/82 millimeters of mercury on discharge. She was readmitted 2 days later with worsening headache. With BP 150/90 stayed in for 1 day to be discharged after adding nifedipine to 20 milligram BT2 labetalol. Her BP was 145/87 millimeters of mercury before second discharge. Now, 10 days after cesarean section, you are seeing her in the accident and emergency. She is unconscious, BP is 130/70, and pupils are constricted. So I can see J and I, two answers here. So basically, what is the key word here? That is pupils are constricted. Pupils are constricted. So basically, that is going in favor of the brain stem bleeding. That is basically pontine hemorrhage. Pontine hemorrhage. It is not CVT. CVT leads to papilledema. Here the pupils are bilaterally constricted. So brain stem bleeding or the pontine hemorrhage has occurred in this patient. So J is the correct answer. And the key word here which points towards the situation is pupils constricted. Okay, the next one. Yes, and here it is. The fastest finger first again. Again, it's Himi6176 username. Very good. That's the second time you have won this. Mrs. LO is a 34-year-old para 1, BMI of 34, delivered her child a week ago by normal vaginal birth. During pregnancy, she developed mild preeclampsia, which did not need medications, and otherwise, all other investigations were normal. She complained in the past of migraine, which usually responded to paracetamol. And following birth, she stayed in the hospital for 24 hours and was discharged home in good condition with BP of 128/82. Referred to the hospital for severe splitting headache and photophobia. First treated as migraine. However, over the following 12 hours, her condition got worse with impairment of level of consciousness. BP of 120/78, urine showing trace of protein and no temperature. Urine showing trace of protein and no temperature. So what is happening here? So that is I is the, okay, yes, correct. Now this is CVT, cerebral sinus thrombosis. This is not brainstem bleeding. You can see here the gradually it is worsening. Then there is photophobia. So this all is in favor of cerebral venous thrombosis. Particularly important is you can be confused by thinking about the migraine, that it is a worsening migraine, but actually it is not, because we have not got the signs like photophobia and all. Then there is level, when the patient is worsening, there is level of consciousness is deteriorating. So now this is a red flag signs. See, the headache questions are asked in the exam. Why they are very important? Because you have to pick up the patients who have the red flag signs and who needs further investigation. So this is one such question where they want to pick you up that it's not a simple migraine which is worsening, but it is something which needs the neurological examination. And that is the purpose of asking this question. And of course, the cavernous venous sinus thrombosis is the correct answer. So I is the correct answer, and who has got it right? Dr. Priyam, Dr. Sunita Yadav, Dr. Shalin James. It's the three amigos, Dr. Yashasvi Pandey, Dr. Yashasvi Pesi, Dr. Malika Burman, Dr. Yamini, Dr. Aruhi. Everybody is fine. Yes, why not intracerebral bleed? That's what I was talking about. Bleed is more sudden, right? Here it is gradually, it is worsening, it's going further, right? Secondly, photophobia. That's also more characteristic feature of this. Intracerebral bleed, patient quickly worsens. That it is. Okay. So any more questions about this? Any more questions about this? Okay. So I mean, you all were very good in answering these questions. So I thoroughly enjoyed the session and hope you also enjoyed the session. You can answer me in the chat box. How was the session? Give me the feedback for that. And secondly, if you feel EMQs are different, then you can have a taste of EMQ shorts in our course, because we have created a very, very short EMQ shorts, which are basically like the Facebook, Insta Reels, or the YouTube shorts for each and every EMQ topic. And you can revise in 5 minutes those particular topic. And this is how you can revise any module in just 30 minutes. So very quick and very quick and clear revision of the EMQs. You can mark what are the answers and you got to know. And I think many of the students are also here, those who are already going through the EMQ shots. If they want, they can write in the chat box also how they feel about the EMQ shots, because EMQ is a big pain point. So I will be going to, yes, Dr. Shalin, you loved it, right? So you are always awesome. Thank you, Dr. Yamini. Thank you. This was a short session, and we'll keep on doing such small sessions to make EMQs further more easy for you. Thank you. It was a good session. Thanks, ma'am. Excellent. Enjoyed. Thank you so much. Thank you so much for joining in and staying till the end. I'll keep doing the sessions. You can also tell me know what topics particularly you want to talk about. You can write in the chat box, and I'll be happy to take those topics again in the next time. If you are still planning to join some course, then this is the one which you can actually have right now. Yes, EMQ shots are great. Yes, so that's what I was telling you, because we always go with 70% less study time, and that's the motto here. So making the EMQs as easy as to do in 70% less study time. So that's why if there are any students who have yet not joined, although I can see many of our students already, but if those are there, then right now we are having the pre-result booking offer going on. You can scan the code and you will get access to everything, including the great EMQ shots as well. And you can have a complete access. And the most important thing is pass with us without reading the guidelines and without reading any books, guidelines, or any other question bank except our website. Yes, thank you, Dr. Arohi. Thank you. So if anybody wants to have a guidance session booked with me, this is a QR code which you can scan and book a session with me. And I'll be happy to talk with you about your exam strategy. Yes, you will definitely do. Definitely join late, but amazing, and you will definitely do. Thank you so much. And bye-bye, and see you again in the next session next time.